Today we're diving into cardiogenic shock, a serious condition where the heart loses its ability to contract and pump blood effectively. When this happens, the body doesn't get the oxygen it needs, and tissues begin to fail. What is cardiogenic shock? Cardiogenic shock happens when cardiac output drops, either because stroke volume is low, the heart rate is erratic, or both. As cardiac output falls, blood pressure drops, and tissue perfusion is reduced. The weakened heart struggles even more, failing to eject blood fully during systole, and fluid backs up into the lungs. There are two main categories of causes. Coronary causes, most common, usually linked to acute myocardial infarction. Damage to a large part of the left ventricle, especially from an anterior wall infarction caused by a left anterior descending artery occlusion, carries the highest risk. Non-coronary causes include severe hypoxemia, acidosis, hypoglycemia, hypocalcemia, tension pneumothorax, cardiomyopathy, valvular damage, cardiac tamponade, and arrhythmias. Clinical manifestations. Patients may experience chest pain or angina, develop dangerous arrhythmias, report overwhelming fatigue or feelings of doom, show hemodynamic instability with low blood pressure and poor perfusion. Assessment and diagnostic findings. To determine severity and guide treatment, cardiac biomarkers such as troponin 1 and B-type natriuretic peptide are checked. Serum lactate is measured to assess tissue hypoxia. Bedside echocardiography evaluates ventricular function. Serial 12-lead ECGs monitor for ischemic changes. Continuous ST segment and cardiac rhythm monitoring are essential. Medical management. The goals are 2. 1. Limit further myocardial damage. 2. Preserve healthy myocardium. 3. Improve cardiac function by increasing contractility, decreasing afterload, or both. 4. Balance oxygen supply and oxygen demand. Correcting underlying causes. Coronary causes may require thrombolytic therapy, percutaneous coronary intervention, bypass surgery, intra-aortic balloon pump therapy, or ventricular assist devices. Non-coronary causes. Treat the root issue. Replace valves, correct arrhythmias, correct electrolyte or acid-base imbalances, relieve tamponade, or decompress a tension pneumothorax. Cardiac arrest patients, once resuscitated, targeted temperature management may be initiated. This involves lowering the body temperature to between 32 and 36 degrees Celsius to protect neurologic function. First-line treatment priorities. Oxygenation. If oxygen saturation is less than 90%, give supplemental oxygen by nasal cannula at 2 to 6 liters per minute. Monitor arterial blood gases and pulse oximetry. Escalate to non-invasive or invasive mechanical ventilation if needed. Pain control. Intravenous morphine may relieve chest pain and reduce preload and afterload by dilating vessels. However, morphine can interfere with antiplatelet therapy, so risks and benefits must be considered. Hemodynamic monitoring. Arterial lines are often placed for continuous blood pressure monitoring and frequent blood draws. Central venous and pulmonary artery catheters may be used to measure cardiac filling pressures, pulmonary pressures, and cardiac output. Fluid therapy. Small, cautious fluid boluses may be given to optimize preload. Never give rapid fluid boluses because they may precipitate acute pulmonary edema. Pharmacologic therapy. Vasoactive medications are central to treatment. Inotropic agents such as dobutamine increase contractility and cardiac output. Vasodilators such as intravenous nitroglycerin reduce preload and afterload, decreasing myocardial workload. Dopamine has dose-dependent effects. At 2 to 8 micrograms per kilogram per minute, it improves contractility and cardiac output. At doses above 8 micrograms per kilogram per minute, it causes vasoconstriction, raising afterload and increasing cardiac workload, an effect that must be avoided in cardiogenic shock. Other vasoactive medications may include norepinephrine, epinephrine, milrinone, vasopressin, phenylephrine, and angiotensin II. Diuretics such as furosemide may reduce pulmonary congestion. Antiarrhythmic drugs are often required because hypoxemia, electrolyte disturbances, and acid-base imbalances predispose these patients to dangerous arrhythmias. Mechanical assistive devices. If medications and fluids are not enough, mechanical support is considered. Intra-aortic balloon pump, IABP therapy. The balloon inflates during diastole, improving coronary artery perfusion. It deflates just before systole, lowering afterload and decreasing left ventricular workload. provides temporary support, typically days. Other devices include left or right ventricular assist devices, temporary artificial hearts, and extracorporeal circulation systems such as cardiopulmonary bypass, used as a bridge to definitive therapy like heart transplant. Nursing management. Preventing cardiogenic shock. Identify at-risk patients early. CANS. Promote oxygenation and reduce cardiac workload by conserving energy, relieving angina, and administering oxygen. Monitoring hemodynamics. Ensure arterial lines and ECG monitoring equipment function properly. Anticipate medications, fluids, and equipment that may be needed. Report abnormal heart rhythms, breath sounds, and hemodynamic values immediately. Administering medications and IV fluids. Monitor closely for fluid overload and pulmonary edema. Document treatments and patient responses. Watch for decreased blood pressure after morphine or nitroglycerin. Monitor IV sites carefully to prevent complications, especially with vasoactive drugs that can cause tissue necrosis if they infiltrate. Review central line necessity daily to reduce the risk of bloodstream infections. Track urine output, BN, and creatinine for early signs of renal impairment. Caring for patients on intra-aortic balloon pump. Adjust timing of balloon inflation and deflation for maximum effect. Check lower extremity circulation frequently to prevent ischemic complications. Enhancing safety and comfort. Relieve chest pain, prevent infection at line sites, protect skin integrity, and monitor renal and respiratory function. Position the patient for comfort and effective breathing. Provide reassurance and use a calm voice and gentle touch. Supporting families. Offer frequent, clear communication. Encourage family presence and flexible visitation. Involve families in decision-making and allow opportunities for touch and conversation. Evidence shows family engagement reduces anxiety and improves overall care experience. Final takeaway. Cardiogenic shock is a life-threatening failure of the heart's ability to pump. Coronary causes, especially large left ventricular infarctions, are the most common. Non-coronary causes include hypoxemia, tamponade, arrhythmias, and metabolic imbalances. Management requires oxygenation, cautious fluids, vasoactive drugs, and sometimes mechanical devices like an intra-aortic balloon pump. Nurses are at the center of care, preventing complications, monitoring hemodynamics, administering treatment, and supporting both patients and families.